Good morning, all. We will take image based questions, and the very first question is from ENT, and it was about a trumpet player and who had presented with a neck swelling, right? So, a trumpet player has presented with a neck swelling, and we can see the swelling here on the lateral part of the neck, and then X-ray was done and CT scan was done. So this is X-ray and this is the CT scan. Now what we can see in the X-ray or CT scan, we can see outpouching something like this. Similarly, in the CT scan, we can see the outpouching like this, right? Which is of course a air-filled cavity, and that's why it is appearing more radiolucent or more black. So this is the cavity here. Clear? Now, to understand Shanvas bhai, absolutely right. This is laryngocele. This is laryngocele. Okay, and whenever we use the word cele, cele actually means cavity. Clear? So here there is a cavity which has formed within the larynx. Now a little bit of anatomy to make your knowledge much more stronger. So this is a section of larynx, right? So this is normal side and this is in laryngocele. Clear? Now what we can see, this is the false vocal cord. Clear? This is the false vocal cord, and below that there is the true vocal cord. So this is the true vocal cord. Clear? So this is the true vocal cord. Now in between the two we can see a space, and this space is actually known as the ventricle. So this space is known as ventricle. So between the false vocal cord and the true vocal cord there is ventricle. Now what happens in laryngocele, there is expansion or extension of this ventricle which is present between the false vocal cord and true vocal cord, right? So if you see here, this is the false vocal cord, and below that we have the true vocal cord. Clear? So this is the true vocal cord, and in between the two, if you see, this is all the ventricle which has now dilated and it is presenting outside. So this is the laryngocele. So this is the, you can say, pathoanatomy of laryngocele, right? So it is the ventricle which actually expands out and it presents as a swelling on the lateral part of neck. So the moment you find any profession in which there is increased possibility of increase in intraoral pressure, or which might be transmitted to the larynx, of course, so that might cause this outpouching of the ventricle which is present between the false vocal cord and the true vocal cord, right? So I think this will now make your concept clear that what actually laryngocele is. I think most of you can answer it, but I just want to discuss a little bit of anatomy which is which one should know in relation to laryngocele. So if you have this concept in mind, I am very sure you will never forget or you will never do any mistake in exam. Clear? So if it comes out, it is external laryngocele. Sometimes it may remain within the larynx, so that is known as internal laryngocele. We are not interested in all that discussion. Clear? So there is outpouching of ventricle which is present between false vocal cord and true vocal cord, right? So this is laryngocele. Perfect. Now moving forward to another question which is from ophthalmology. Now here you can see like this. This is actually the complete visual field, something like this. Now what is shown in the image, that vision is present only in this half, in both the eyes, right? So say if this is the left eye, just take it like that, or this is the right eye. right? So the vision is present only in one half, and this half is the nasal half. Clear? So this is the nasal half, and on this is the temporal or the lateral half. Clear? So temporal, you can say lateral, right? So this is also temporal, or you can say lateral. Nasal is of course medial, right? So this is medial. Now what you can interpret from this image, that there is vision only in the nasal half, but there is no vision in the temporal half. Clear? So no vision over here, no vision in this area. Clear? So the vision is present only in the nasal half. There is no vision in the temporal half of both the eyes. So when we say both the eyes, so we have to use the word bi. If we have to mention the lateral field or temporal, so we will write the word temporal. Now this is exactly the half of the field, half of the visual field. So we will write the word hemi. Very good, Shanwaz bhai. So we will write the word hemi, and now there is no vision, right? So in this part there is no vision. So for no vision, what we shall write? Anopia. Clear? So this is the picture which is shown here. This is bitemporal hemianopia. Bi means again both, temporal, that is lateral, hemi means half, an means absent, and opia means vision. Clear? So there is bitemporal hemianopia. Now when I say bitemporal hemianopia, what is the site of lesion? So you have to identify the part of the visual pathway where the lesion has occurred. So to understand this, we need to take the visual pathway first. Although it is very easy to answer, the answer is, I think most of you can say, this is optic chiasma, right? So the answer is optic chiasma. But I want all of you to understand what actually optic chiasma is. So I have taken one image to highlight this. Now remember one thing, in a visual field there are two parts, like the medial part, the nasal part, and the lateral part, that is the temporal part. So if I take the temporal part, okay, and this is, say, the nasal part, right? So this is the nasal part, say. So from the surroundings, the image forms on the retina in a crossed manner. Clear? Now when I say crossed manner, what does it mean? So it means that this is the temporal field, means whatever I am looking from in the lateral part of my visual field, and this is the nasal field, whatever is on the medial side of my visual field. Now these cross over, and on the retina they project on opposite ends of retina. So the nasal wheeled fibers, they will go to the temporal part of retina. Similarly, the fibers or the images which are coming from the nasal from the temporal field will fall on the nasal part of retina. Is that clear? So from outside to inside, from inside to outside, please remember that. So there is a cross before the images they fall on retina. Clear? Now after the retina there will be optic nerve. Clear? So from the retina there is coming the optic nerve. An optic nerve has two fibers. One fiber is the nasal fibers. Clear? So these are taking the impression from the nasal side of the retina, which is carrying the impulse from the lateral part of visual field, right? So you can remember it like this. And there are temporal fibers of the retina which are carrying the visual impulses which are coming from the nasal side of visual field. Okay, so this might sound little confusing because the terms like nasal visual field, nasal retina, and nasal fibers of optic nerve. Okay, so this is the temporal fibers of optic nerve. Clear? And on the other side, these are nasal fibers of optic nerve. Now what happens? Similar fibers are coming from other eye as well. So you can take it like, suppose this is right eye. So the same fibers are also traveling from the left eye. And what happens? Just at an area above the level of pituitary gland, there is crossing over of the fibers only of the nasal side. Clear? And the temporal fibers, they continue on the same side like this. So this point of dissociation, if suppose this is the fibers from the other eye, this is of course the nasal fibers. I'm sorry for. Clear? So this is again the nasal fibers of, you say, left eye, and the temporal fibers, they will simply continue on the same side. So what I mean to say that the nasal fibers, they change over their position at optic chiasma. So this region is known as optic chiasma. Okay, after this becomes the optic tract. So this is the optic tract. Clear? So if there is any pathology in this area, in the region of optic chiasma, there will be damage to both the nasal fibers of the optic nerve. Now nasal fibers are continuing from the nasal part of retina, and this nasal part of retina is actually carrying impulse from the temporal visual field. Therefore, if these nasal fibers are damaged, there will be no image from the temporal field of both the eyes. So we get bitemporal hemianopia. The temporal fibers are continuing unaffected, but the temporal fibers are taking the impulses from the nasal field, and therefore if we see here on the nasal side, patient is having perfect vision. It is only the temporal fibers it's only the temporal visual field, there is no vision. The vision from the image from the temporal visual field is carried by the nasal fibers of both the optic nerve, and both the nasal fibers, they actually dissociate at the level of optic chiasma, and if there is any damage at the level of optic chiasma, it will lead to damage to nasal fibers of optic nerve of both the eyes, manifesting as bitemporal hemianopia. Clear? So this is a very unique concept. It is not simple, straightforward. You have to little bit understand that. Right? So this is bitemporal hemianopia, damage to both side nasal fibers, and this can be seen in relation, especially in cases of pituitary tumors, because this optic chiasma lies just above the pituitary gland. So if there is any tumor, it will simply compress the optic chiasma, right? So a very beautiful concept, and yes, this question is repeated many number of times, either as a simple straightforward fact, sometimes clinically based question, or at times straightforward image based question. So you have to understand what actually is being shown, and if you apply this concept you will never be wrong, right? So this is related to optic chiasma. Okay, so even if you look in this image, this is the nasal fibers here. Okay, so these are the nasal fibers, and the nasal fibers, they are taking the image from the temporal side of visual field. Clear? And at the level of optic chiasma, the nasal fibers of both the optic nerve, they cross over. So I'm not going into the entire detail. I was just focusing on bitemporal hemianopia and what is the anatomical basis of that. Clear? Now moving forward, a basic question, but I think little difficult if you haven't seen or if you haven't done that, right? So here a person was having gross abdominal distension. Now which test is done? Now when we say, very good Shanavas bhai, when we say distension, we actually means it is ascites, and ascites is collection of, very good, collection of fluid in peritoneal cavity. Clear? Now I think looking at the image, you can go for straight away, you can say it's a fluid thrill test, but I'll just explain the basic method. So what actually we do when we see a case of ascites, and if we want to confirm that yes, it is a collection of fluid, we will put the palm on one side, right? So palm on one side, and we will stroke with a finger from other side, right? So palm on one side and stroking with a finger, just like playing carom, we will stroke from one side. Now if there is a fluid, these vibrations will be set up and they will be traveling all the way to the opposite palm, right? So there will be vibrations which will be set up in the fluid and they will be felt in the opposite palm. Now if you see in the image there, usually we tell the patient to keep the hand, the medial border of the hand in the middle of the abdomen, right? Now what is the purpose of keeping this hand here? The hand is placed because we want to block vibrations set up in subcutaneous fat, right? So if we don't block these vibrations, then there is possibility that if we don't block the vibrations of the subcutaneous fat, it can be mistaken as a vibration of the fluid in the abdominal cavity, and maybe the person is obese and you may label him wrongly as ascites. So you have to put a hand in the center, and we just want to make sure that the vibrations of the subcutaneous fat are not transmitted to the palpating palm, right? So this hand just blocks the transmission of the vibration through the fat, and simply the vibrations through the fluid will go to other side and that will be perceived by the palm. So this is fluid thrill test for ascites. Very good. Now what is being measured here? Again, this is an ENT. Yes, Shanavas bhai, absolutely right. Now what is being measured here? You can see an instrument and it is kept over the eye, and this is actually measurement. No, this is an old method. So measurement of intraocular tension, right? So IOT or IOP, intraocular pressure. Intra means inside, ocular is of course eye. So we want to measure the pressure within the eye, and this instrument is actually Chiod's tonometer. Previously it was used in wards and all, but nowadays we don't use it, right? So not preferred nowadays. Clear? Nowadays we used no contact tonometry, NCT, means we don't contact the eyeball, and this is the better is, yes, of course, applanation tonometer. Clear? So this is applanation tonometry, that is the preferred procedure nowadays, right? So this is an old method where we used to keep the instrument, but here the problem was that sometimes the scleral rigidity might give a falsely high value, right? Might affect the values. So maybe the sclera is rigid and the pressure will come out to be high, and then we might label the patient wrongly as a patient of glaucoma, right? So this is not done nowadays. It's just a historical method. Nowadays we prefer applanation tonometry, that is no contact tonometry. And yes, IOT, it is a very valuable investigation for glaucoma in which the intraocular pressure is raised. Clear? So this is Schiot's tonometer, not done nowadays. Now this is a very favorite question. Every year I see at least one question from this either imaging modality or simple line diagram. So every time we have a question from this, and here it is being asked like, what is this red structure? Now this is a transverse section of brain, and it is being asked like, what is this red structure? Very good. This is caudate nucleus. Very good, Shanvas bhai. This is caudate nucleus. We can discuss other things as well. Now, if you see, you can see one structure over here, and this is the putamen. Clear? This is the putamen. Then deep to putamen we have globus pallidus externus and globus pallidus internus. Clear? So globus pallidus, yes, right, globus pallidus, and then this is externus, and deep to that is globus pallidus internus. Clear? Yes, of course, if putamen plus globus pallidus is named collectively, it is named as lenticular nucleus. So sometimes in description you might find these words, lenticular nucleus. So lenticular nucleus is just putamen and globus pallidus. Clear? Then on the medial side we will see thalamus, right? So here this is all thalamus. Clear? So this is thalamus here. Now in between these structures you can see one area. Now if you see here, this is an angulated area, right? So what is this? Something like this, angulated outside. So this is internal capsule, right? So please remember this diagram. It is very important, and many times we have a question from this. So caudate nucleus, putamen, globus pallidus, internal capsule, thalamus, right? So please remember it. Chalo, moving to next question. Image has been shown and there are two nerves which are running across, and I think it's very easy to identify the nerves. If you see here, this area is the medial epicondyle, right? So this is the medial epicondyle of humerus, and the nerve is passing behind that medial epicondyle. So obviously this nerve is ulnar nerve. Clear? The other nerve is passing in front of the elbow, and this is the median nerve. Right? So median nerve passing from the front of elbow and ulnar nerve passing behind the medial epicondyle. Now I'll tell you one more trick based on which you can identify that which are these two nerves. Now if you track this nerve which is passing behind the medial condyle and then going up to the hand, it is supplying this much area. Right? So this nerve is supplying this much area in the palm. Clear? And if you track the other nerve which is passing in front of the elbow, it is supplying this much area. So if you can just, mark out these structures and these areas on the volar aspect, you can also answer the two nerves, because this nerve is supplying 3.5 and this one is supplying 1.5. Clear? So 1.5 is medial side, because little finger is medial side, and 3.5 is on lateral side. Clear? So this way also you can associate your answer. Okay, so this is of course the volar aspect or the palmar aspect. Clear? So that way you can associate. Thumb side is lateral 3.5 is median nerve, and little finger side 1.5 is ulnar nerve. Now I'll request you to remember one thing. On the volar aspect of the hand or the palmar aspect of the hand, it is all territory of median nerve and ulnar nerve. There is no entertainment of radial nerve here. There is nothing related to radial nerve here. So if you see anything related to volar aspect or the palmar aspect of arm, if you don't know the answer, please play the guesswork either between median nerve or ulnar nerve. Although I expect all of you to answer it correctly, because this is a very important segment. Always and always we have a question, either in terms of area of involvement, either in terms of clinical test or clinical science. So median ulnar nerve are extremely important. Right? So I'm skipping the radial nerve over here just to avoid any sort of confusion. Right? Although the radial nerve passes like this, right, behind the humerus, and it will come on the lateral side of the, right. So this is the area of radial nerve. Clear? Right? So this is radial nerve on the lateral side. Medial is ulnar nerve, in the front is median nerve. Yes, Shanavaz bhai, you are absolutely right. I'll skip that part because I don't want to go into theoretical details. Okay, so I'm just concerned with the images, and I just want to make sure that you know the answers very well and there is no confusion in the exam whatsoever. Right? So for this particular image, I'll request, please remember median nerve, please remember ulnar nerve, and do not entertain radial nerve in relation to this question. So we can skip it from here so as to avoid any sort of confusion. So median and ulnar. Right, Chaitanya? Chalo, moving forward. Now, what muscle is shown in the image here? I think it is very easy to identify. Most of you must be knowing the answer, but those who don't know the answer, let me tell them the trick. Now, this bone is scapula. Clear? This bone is scapula, and in the scapula there is a spine. This is the spine of scapula. Clear? And then this spine continue as the acromion process. So this is the acromion process. So this is the anatomy of scapula. Yes, Shanavaz bhai, absolutely right. Now here there is one muscle which is originating at an area above the spine. So we can use the word supra for spine, supra for above, and of course spinatus for the related to the spine of scapula. So supraspinatus. Simply, if I ask you which muscle is this, now this is originating below the spine, so your answer will be infraspinatus, right? So I think this will help you. So sometimes in anatomy especially, you can apply a simple logic and you might reach up to the answer, right? So this one is of course supraspinatus, which is shown in green color, and the one which is shown below is infraspinatus, right? So supraspinatus, infraspinatus. And if you go even lower down, you will see one muscle here. This is one muscle. This is teres major, right? So this is teres major, and on the top of that you can see one small muscle, and this is the teres minor. Very good, Chaitanya. So this is teres minor, right? So what I want to show you, like suppose if this is teres major, the teres minor is above that. So what I want to show you, major is below, minor is above. Clear? So you can remember this arrangement, and the term teres you have to remember, and you can mark out these four muscles in relation to scapula. Clear? Supraspinatus. So this is supraspinatus, infraspinatus, teres minor, lowermost is teres major. Okay, chalo. Now this is one more very beautiful question, although from a very basic fact, but presentation might look difficult to student. So there is left ventricular, right? So this is left ventricular pressure volume graph. So it is related to pressure and the volume of left ventricle. Now it is being asked what phenomena will occur at the point C. So this is the point C. So let me see if anyone can answer this. We are discussing the pressure. Now this is the pressure here, okay, and this is the volume in this axis. Volume means the amount of blood, of course. Okay, right now here, firstly let me tell you a simple fact about the cardiac cycle. Now what happens, suppose if we start from isovolumetric relaxation, let's start with contraction first. IVC. Now we are taking only left ventricle part, right? Now what will happen? What does iso means? Iso means same. Volumetric means the volume of blood. Contraction means the ventricle will start contracting. So isovolumetric contraction. So it means the ventricle is contracting, but the amount of blood within the ventricle will remain same. Now how it will remain same? It means the valves above and below the left ventricle are closed, right? So the mitral and the aortic valves are closed, and the ventricle is contracting as a closed chamber. Neither any amount of blood will flow in neither any amount of blood will flow out. Clear? So the amount of blood within the left ventricle will remain as such, and then the ventricle is contracting. Now as the ventricle will contract, the pressure within the ventricle will keep on increasing. So this phase is IVC. Clear? The volume is same, around 120. Volume is same, but the pressure is increasing gradually, right? So pressure firstly 20, then it became 40. So you can write here 20, then 40, 60, 80, like that. Okay, so we are just correlating with this side. So it will be 80, something like that, right? So the pressure is increasing, but the volume is same. And why the volume is same? Because the mitral and the aortic valves are closed. Neither blood can flow inside the ventricle, neither the blood can leave ventricle. So it is IVC. So this part is isovolumetric contraction. Now what happens when the ventricle will keep on contracting and when the pressure in the ventricle will keep on increasing? A time will come when the pressure in the ventricle will be much more than that of aorta, and therefore the aortic valve will open, right? So aortic valve opens, right? And when the aortic valve will open, the ventricle will contract. It means pressure will continue to increase and it will push the blood into aorta. So what will happen? Pressure will increase because it is contracting, but since the blood is flowing into the aorta, so the volume will decrease. Clear? So we can see here that the volume will decrease as the blood is being pumped out into the aorta, right? So this phase is the phase of ventricular systole. The blood has been pumped out from the ventricle into the aorta. Now when the blood has been pushed into the aorta, obviously the pressure in the aorta will be high and the pressure in the ventricle will be less. So what will happen? The aortic valve will close. So here this is aortic valve closed. Now mitral valve is already closed. Aortic valve has now closed. So what will happen? The ventricle will again become a closed chamber. Now after systole, it will go into diastole. So this phase is known as isovolumetric relaxation. So this phase is isovolumetric relaxation, and the word isovolumetric, I think all of you must understand by now. The amount of blood will not change, and relaxation means the pressure will start declining, and therefore you will see the pressure is going like this. So pressure is declining, volume will remain same. Now as the ventricle will keep on relaxing, a time will come when the pressure in the left ventricle will be lower than the pressure in left atrium, and the moment the pressure of left ventricle is lower than that of left atrium, there will be opening of mitral valve. So mitral valve opens, and when the mitral valve will open, blood will flow from left atrium to left ventricle, and therefore we will see that the volume of blood will increase, right? So the volume of blood will increase, and again when the volume of blood will go into left ventricle, the pressure in the left ventricle will increase as that of left atrium. So there will be closure of the mitral valve, right? So this is mitral valve closure, right? So this is the cardiac, the ventricular left ventricular pressure volume curve. When the pressure is increasing, when it is decreasing, when the volume is increasing, when it is decreasing, you can correlate with the cardiac cycle, right? Now this is about left ventricle. The same process will be carried on in the right ventricle as well. So please remember this, and it is not that difficult. It just need a little bit of application of the knowledge, because I think theoretically you might be knowing everything, but how it is plotted on a graph, that needs little bit of application of knowledge, right? So what you need to see, if the pressure is increasing and the volume is decreasing, it means the heart is in, the ventricle is in systole. So obviously it can go only in systole, proper systole, with the ejection of blood, when the aortic valve will open. Then only it can pump the blood into aorta. So the volume will decrease, pressure will continue to increase. So this point C is aortic valve opening. Clear? Would it have been a case of right ventricle, then answer would be pulmonary valve opening. Clear? So very beautiful concept. Yes, need a little bit of time. Now moving forward, which condition will shift the given curve to right? I think most of you will understand that this is a sigmoid curve, S-shaped. Sigmoid means S-shaped. Okay, and so this is S-shaped, and what we can see here, partial pressure of oxygen, hemoglobin saturation on the two axes. So when I say shifting of oxygen, hemoglobin, this is of course oxygen, hemoglobin dissociation curve, right? Now dissociation means separating. So it means the oxygen will separate from hemoglobin or not. And because we know that hemoglobin is the carrier of oxygen, oxygen itself cannot transport into the blood. It needs a carrier, and that is hemoglobin. So it remains bonded to hemoglobin. So if we say right, it means the oxygen will be released. Okay. So it means the oxygen will be released. And how to remember? Remember R of right and R of released. So if I say the curve is shifting to right, it means oxygen will be liberated into the tissues from hemoglobin. Now these are those conditions where body needs oxygen. If the body needs oxygen, definitely it will come out from hemoglobin, and therefore the curve will shift to right. So of course one is increased PCO2, that is increase in partial pressure of carbon dioxide, which results in decrease in pH, and this is acidosis. Yes, perfectly right, Shanavas bhai. So increased PCO2 or decreased pH, same thing, just words are different. Apart from this, raised temperature. Clear? If the temperature is high, body, the hemoglobin will be released, oxygen will be released from hemoglobin. Third is increased 2,3-diphosphoglycerates, also written as biphosphoglycerate. It's same thing. And this compound is increased during exercise. Right? So there are three conditions which you need to remember at least. Increased PCO2, which is synonymous with decreased pH, acidosis, that is respiratory acidosis. Increased temperature, increased 2,3-DPG, which is increased during exercise. Right? So remember these much points. Okay? Then moving forward to one more beautiful question from biochemistry. A curve is shown, and this is about enzyme inhibition. Now, what is this curve? It means what type of inhibition is this? Right? Whenever we have to discuss enzyme inhibition, we discuss two terms, Km and Vmax. Clear? So Km and Vmax, and what you can see in this particular image. Now let me show you the Vmax first. Very good, Chaitanya, very good. But let me explain how we can reach up to the answer. You might just memorize, oh, this is competitive, but I think it's my duty to explain the thing so that you should know why we are getting that answer. Very good, Shanavaz bhai. So if you see, this is Vmax, and whether there is no inhibitor or whether there is inhibitor, Vmax is same, right? So Vmax is same in both the conditions, whether enzyme inhibition was there or not. So it means Vmax is same here. Without inhibitor, in the presence of inhibitor, so Vmax remains same. Now let us take the another entity, and that is Km. Okay, so let us take Km. Now Km, when there is no inhibition, this curve is about without inhibitor. Okay, so enzyme substrate reacting and forming the products. So this is at this point in this graph, you can see the Km is here, right? So this is the Km without inhibitor. Now when a inhibitor is added, see what has happened. The curve is going like this, and therefore the Km, this is the new Km, and this curve is with inhibitor. Clear? So what we see here, that when there was no inhibitor, Km was less. When a inhibitor was added, Km increased. So Km increased from this to this. So it means Km has increased. So Km has increased from this value to this value, but Vmax is same for both, whether inhibitor is there, whether inhibitor is not there. Yes, so Vmax is same, Km has increased. When you see this kind of graph, the answer has to be competitive. Clear? So this is competitive inhibition of enzyme. So I think now you will never forget a competitive inhibition graph. Km will increase, Vmax will same. Now if you see here, the Km, it refers to affinity of enzyme to substrate, because we know that enzyme plus substrate, this results in product. This is enzymatic reaction. So if the Km is less, it means the affinity is more. So this is inverse relationship, right? Less Km, more affinity. Now if you see here, when we have added the inhibitor, the Km has increased, right? So Km has increased. Now what does this mean in terms of affinity? It means the affinity of the enzyme towards substrate has reduced. And why it has reduced? Because it has already, it is binding to the inhibitor. Therefore, its attraction for the substrate is now less. It is more attracted to the inhibitor. So therefore, Km increases. It means affinity decreases. Okay, and this is the concept of Michaelis-Menten coefficient, that is Km. Shanavaz bhai, I am just trying my level best here. Okay. So Vmax is the maximum velocity of the enzymatic reaction. It remains unchanged whether inhibitor is there or not. Vmax is the velocity of reaction. Clear? So my sincere request is that please try to understand the basic concepts, and I'm very sure you will never be wrong in the images if they are there in the exam, right? So for competitive, just take the words Km will be high because affinity is less, and Vmax, there is no effect in competitive inhibition. Clear? So I'm not taking other types of inhibition because I want to avoid mixing up of the facts. Therefore, if you see in most of my presentations, I prefer discussing one entity at a time, not the other related entities, because it all lead to mixing up, right? So this is the end of today's session, and I'm very sure like you must have enjoyed the session. So stay tuned. I'll come with many more interesting images, and I'll try to give you a basic trick how to reach to the answer, and obviously I'll try to explain the underlying concept as well. So thanks for sparing your valuable time. Stay blessed. Keep on studying. Bye bye.